Good afternoon, everyone. Welcome to the Health Talks, a production of Arizona State University's College of Health Solutions. As a reminder, this webinar is being recorded and will be posted to public websites. If you have any Q&A that you would like to ask, there is a Q&A box at the bottom of your screen. We ask that you put all questions in that box versus the chat function. That way we can monitor it. It is my great pleasure to introduce Dr. Carl Yamashiro, Associate Clinical Professor at Arizona State University. Go ahead, take it away, Carl.
All right, good afternoon, everyone. Again, on behalf of the College of Health Solutions at Arizona State University, welcome to the Health Talk speaker series, which this webinar will cover COVID-19 and effective diagnostics, the key to recovery of health, society, and the economy. My name is Carl Yamashiro. I will be serving as a moderator for this webinar. Very briefly, as Marcus mentioned, I am an Associate Clinical Professor and Program Coordinator for the Biomedical Diagnostics Master of Science degree program. I also have over 25 years of industry experience in the diagnostics field. Today, we are all painfully aware of the coronavirus disease 2019 crisis, more commonly called the COVID-19 pandemic. It has dramatically altered how we work, study, and live today, and will continue to prevent us from going back to something close to resembling our quote-unquote normal lives for probably quite a few months and possibly more than a year from now. As it became evident that the causative agent for this serious new disease was a novel coronavirus, it was imperative that diagnostic tests be developed to initially determine if individuals are infected with the COVID-19 virus. There was a general call for companies, healthcare facilities, even individuals to develop and deliver such tests. Soon after, there was even a demand for other types of tests to at least determine if individuals have been infected by the virus based on that individual's immune response to it. Today, I'm very excited to introduce to you two speakers to tell us more about these tests and how Arizona State University has risen to the general call for COVID-19 testing. Our first speaker is Mara Aspinall, a professor of practice at ASU, co-founder of the Biomedical Diagnostics program within the College of Health Solutions. Mara has served in a number of executive leadership positions, including president of Genzyme Genetics and president and CEO of Ventana Medical Systems. She's currently the managing partner for BlueStone Venture Partners and serves as a director for a number of company boards. Our second speaker is Joshua LaBaer, who is a professor and executive director for the Biodesign Institute at ASU, as well as the center director for the Virginia G. Piper Center for Personalized Diagnostics. He is a current member of numerous editorial and scientific advisory boards and is a member of the National Cancer Institute Board of Scientific Advisors. Both speakers will be giving their presentations, and then there will be, as Marcus mentioned, a Q&A session immediately following the talks. So again, please submit your questions to the Q&A box, and the speakers will address as many of them as possible during the time available. In addition, this webinar is being recorded and will be made available not too long after this ends. So now I want to welcome Mara Aspinall as our first speaker.
Thank you, Carl. I am very pleased to be here and talk about this important topic. And as you said, we're going to talk about diagnostics and them being the key to the beginning, middle, and end of the COVID-19 pandemic. Let's first talk about the devastating toll of COVID-19. As of last night, in the US, there were 673,000 cases with 30,000 deaths. That equates to a 4.6% death rate. And if you extrapolate that out, it gets even more devastating. If you assume that patients who are coming in now die at 14 days after their positive control, the death rate may rise to as much as 13%. So with that backdrop, we have to talk about what this is. And it's important to understand that this is the disease versus the virus. So first, let's look at the virus. So if we look at the virus on top, it is severe acute respiratory syndrome, SARS, coronavirus 2. And for those who studied Latin may remember that corona means crown and it was initially called coronavirus because it looked like a crown in its initial shape. But this differs from the disease itself, which is called COVID-19 for coronavirus in 2019. And you can see at the bottom here, this is an example of a 77-year-old man. Day 5, very few infiltrates in his lung CT. Day 15, the start to dysfunction. Day 20, tremendous dysfunction in his lungs. And unfortunately, by day 30, he did die. So this gives us a sense of the importance of this disease and controlling it earlier rather than later. So the question everyone asks, the rallying call, tell me about the diagnostics. Do I have it? Do I have the antibodies? So first, to give you the historical meaning just 3 months ago, how has this developed? Well, there's no ability to create a diagnostic unless you have the gene sequence of the virus. And that was done in middle of January. And just 3 months later, today, we have more than 650 coronavirus 2 tests. And when we talk about those tests, what are they? Whose are they? Well, at last count, there are 665 tests. They're created by 552 different companies. About 55% of those tests are the viral test looking for the virus itself. I'll talk more about that. And about 45% are looking for the antibody to that virus that hopefully confers immunity. By definition, a pandemic is global. And as you'll see here on the right-hand bar, that the tests themselves are global, with about just over a third of the tests coming from the US, 60% coming from China or other countries. So in order to make these tests available, the FDA took an unprecedented step on April 1st with a major relaxation of traditional constraints. This is from their town hall talking about the policies, 4 different policies regarding FDA approval and notification vis-a-vis COVID-related tests. Let me highlight a couple of changes. First, what you can see is for the first time ever, the FDA has enabled individual states to approve manufacturers to use their tests in that state. But maybe most importantly, what they've changed is the communication to the FDA around EUAs, emergency use actions. And what you have today is the FDA is not requiring any communication. And when they do ask for it, they are requesting it, but it can happen indeed after the testing has initiated. That is unprecedented. But maybe even more important is the fact that to date, they have not issued any EUAs for home tests. It's my belief that they will do that, but that has not happened yet. So the question that comes up is, if there are so many tests, why can't I get one? As with so much in the life science community, there's a number of subtleties here. So I believe there are 3 key questions that I'll talk about in this webinar. Number 1, what is the difference between a test for the virus or a test for the antibodies? Number 2, what does it matter if they use a nasal swab, an oral swab, if I spit, or use sputum or blood? And I'll tell you, it matters a lot. And lastly, and moving forward, critical, how do we use testing to open up society again? So first, it's important to note there were 2 very different questions and they require 2 very different tests. On the left in red, and I'll continue that throughout the presentation, we have a question of, do I have COVID-19? In order to answer that, the tests are looking for the virus. Is the virus present? What's critical to understand here is the sensitivity. We want to never miss a case. Essentially, no false negatives. On the right-hand side, and what I will continue to box in green, is the second type of question, second type of test, which is, do I have the antibodies to fight off this virus? And here, the specificity is critical. So it means immune really means immune. There are no false positives. We don't want to be telling someone they are immune from the virus, they can fight it off, but indeed they are not. So how does this work? Well, on the right again, the test for the disease, what we're looking for is the RNA genome or the RNA protein. We're looking to see if the virus is present. Some of those tests, but not all of them, also talk about viral load, the number of virus copies an individual has. That is important because for two reasons. What we believe is the larger number of viruses, the more likely the person is to get symptoms. And if they have symptoms, the more copies, the more likely it is for that person to get very severe symptoms. Secondly, we'll go back to the immune side. And what you look for here on the immunity is both during symptoms to see, is the body building defense, what's called IgG antibody? Is the body starting to fight this infection? And then before and afterwards, we look for that presence of the antibody. We do know from other viruses it's a defensive immunity, but we still don't know, since this is so new, how long that immunity will last and how effective it is. So let me give you some examples of a study of recent patients. And what you see, again in red, is the virus. On day one, 100% of patients indeed have the virus. And that slowly goes down over a 3-week period. But interestingly enough, at the end of this 3 weeks and 21 days, still 35% of the patients still have viral DNA. That is different from the IgG or the immunity marker. And what we see here is vast changes in the percent of patients that have that IgG building. It typically crosses over at about day 12. Doctors talk about it day 14, where you'll see dramatic improvement in symptoms. And this, in this study, increases steadily from day 12 to virtually 100% of those patients have the IgG antibodies at day 21. So if you understand the basics of the test, how are they being done? Well, on the left in red, the COVID-19 tests. The largest number of tests are being done in a central lab. They can be done in an automated fashion or in a manual kit, but there's also a tremendous number of tests being done in a point of care system like the Cepheid Gene Expert, or soon in newly approved and developed systems like a Q Health small box. So this is the test again, do I have the virus? But let's look at the test for what's typically called serology assays. You may have heard that, immunoassays looking for those antibodies. Again, that could be done in a central lab in an automated fashion or in a manual fashion. But again, here we have these point of care or near patient tests. The most common ones here are finger stick, where a test is used to get blood from the tip of a finger to get an answer as to whether they're antibody. The good news for these antibody tests is if it's anywhere, it's everywhere. So getting a little bit of blood allows you to be able to get an answer to that immunity. But as with everything, there are pros and cons. So let's start again with these PCR tests, viral tests. Do I have the virus? And let's look at the pros and cons. First, they are nasal swabs. They are non-invasive, although if you've had one done, it kind of feels a little invasive and quite uncomfortable. But they are quick. They're exquisitely sensitive and specific. They show 100 virus copies on an individual swab. And to give you a sense of that, a positive patient may have 300,000 or more copies. So that 100 copies certainly should be able to give that answer. But sampling, as I said, is hard. This is a disease of the lungs, so the nasal and oral swabs may not reach deep enough. Process is critical. Saliva, we don't know. Sputum is a great sample, but rarely do these patients have a wet cough. Most of them have a dry cough. What has been critical to understand and why it takes so long is cross-patient contamination. This is critical, and the smallest bit of contamination will yield false positives. The central lab model takes 24 hours, mostly longer than that. And the inflammatory storm that has unfortunately killed so many young people with the disease, which is why it's called biphasic. They look like they're recovering, and then they get this inflammatory storm, cannot be detected through these tests. So what are the pros and cons for the immunoassays or the serology tests? Here, we need a blood sample tube. Very common. Everyone's familiar with it. Everyone's familiar with a finger stick system. The technique for sampling is not really an issue. It's very standard. But the antibody design is both an art and a science. I'll talk more about that in a little while, but what we have is a vast range of effectiveness for different tests, from 40 to 90%. And as this is moving so quickly, very few companies have indeed disclosed their scientific details yet. Cross-reactivity here is not about cross-patient contamination. What it's about is the 5 other respiratory coronaviruses in the world today. And what's critical is these antibodies need to be specific to the current COVID-19, not to any of the other coronaviruses. False positives, like always, are dangerous, especially for healthcare workers. So what does this effective sampling technique look like? As you could see on the left, the samples are taken from the nose, the mouth, or the trachea, or a more aggressive procedure to go into the lungs. But the key here is that the success rate is not nearly what we all hope. The success rate for the oral swabs is about 32% in one large study. NPS, much better, but still only 63%. And you remember I mentioned sputum. It's great, but you need a productive cough. The bowel procedure, doing an invasive procedure, is indeed 100% successful, but highly invasive, at danger to the physicians doing the test and, of course, the patient. Saliva, we don't know yet. Yesterday, there was a test announced that was a saliva test, but no data has been published yet on the success rate of the sample itself. But watch this space. I'm sure there will be more there. Why is this important? Well, let's look at 2 patients, patient A and patient B. They were infected at the same dinner, both hospitalized, one at day 20, one at day 15. And what you could see here is while all of their testing started out positive, either by day 25 or by day 22, some of the testing was negative. And this study saw that 36% of patients during their hospitalization, while they're still fighting the virus, had at least one test that came out negative. So it only emphasizes how important it is to be very careful with our sampling techniques. So that's on the virus side. Now let's look at the serology side. I mentioned earlier that we know the genome for the SARS-CoV-2. It's a little cartoon up here. It's about 30,000 base pairs. And to give you a sense, that compares with us as a full human of about 3 billion base pairs. I'm first going to compare this to the bat coronavirus. It's about 96% overlap. I say this because this is the reason that we believe that this virus indeed started in bats. But more relevant to people are other coronaviruses. The current one has about 80% overlap with the SARS 2002 virus. And that emphasizes the importance of designing an antibody test that is specific and unique to this SARS-CoV-2 virus. So as I come to a close here, I wanted to bring together how much testing we've done and where do we go from here. If you look at the testing across the US, what you see over the last month is we've done between 100,000 and 150,000 tests per day. Sadly, this testing number has not measurably increased over this period of time. The positive rate is about 20%. So if we take that data and we look at the immense diagnostic challenge from a big picture point of view, Let me go through what this might look like from the full United States. We start with the US population, 330 million people. We're all in lockdown and sheltering in place now to avoid exposure. So we go with a model that the experts have suggested, which is that 50% of us are never exposed, but that leaves 165 million to be exposed. If we take from there that 50% will have no infection evident, but 50% will, those symptoms will appear between 2 and 14 days or impact 83 million. You go from there and you say, as has been typical, 75% will have mild symptoms and will not need hospitalization at all, but 25% will indeed have very serious symptoms. This is the point at which the testing has happened to date. These are the viral tests, and that what we see here is of these 25%, 80%, assuming today's rate, this will probably increase as we go to a larger number of people in the population, but I'm using the current rate. And what you will see is roughly 4 million people from a model point of view across the US that are hospitalized. And if we take the death rate today at 4.6%, but we're optimistic that it only goes up to 5%, we have 95% recovered and 200,000 who have died. This gives you a sense of the viral test, but maybe more important as we look to reopening our society is on the right-hand side in green. The tests that are critical, whether you call it the golden card or otherwise, saying that we need to know whether each of us and the people one works with and plays with have the antibodies to SARS-CoV-2. This, I believe, could be as many as 40 million tests. At the current pricing at $40, this is roughly 16 billion. If you add that to the acute viral infections where the pricing is roughly $90 today, you get a total of about $20 billion in cost. At first blush, it feels like a large number, but if you compare that to our economy and our GDP at 2 to 3 trillion a month, it's actually relatively small. So in conclusion, what I believe needs to be done going forward is fivefold. Number one, testing must increase tenfold from the current levels. Tests need to be widely available, but with data, and the FDA needs to police for misleading claims. All testing must be free, so there is no disincentive to be tested. I believe we need testing at home, but we need to ensure that they are responsibly done and, excuse the phrase, idiot-proof, that each of us cannot make a mistake and you get an accurate answer. Number two, effective treatment protocols established. This has started, but we need to do nationwide data collection on current hospital practices, share what's working and what doesn't work, and we need to collect phase 4 type data. Number three, effective case and positive contact tracing. This has worked so well in other countries. Understand that there are a number of concerns about privacy, but we need to really investigate what the smartphone companies have done and what they believe is possible with the technology that virtually all of us own. Number four, intelligent focused quarantine and isolations going forward, so we don't all need to be home. I believe that will happen on patient segmentation. I believe it's less focused state by state, but needs to be done on a county or SMSA basis. And lastly, I believe there will be a second surge, and we certainly need to re-engineer at least some of our hospitals to be ready and adaptable for infectious disease surges in the future. So with that, I look forward to Josh's talk and having the chance to answer your questions. I will end, though, with another thank you for our healthcare workers for their strength and their courage to keep us all as safe as possible. Thank you.
Thank you, Mara. And now we are going to have Josh LaBaer as our next speaker.
Okay. Hopefully everyone can hear me. Let's see, did this, all right, that
We
should
can hear
be
you, Josh.
good. Okay, and you should be able to hopefully see slides. So
Yep.
yeah, I'm gonna, thank you, Mara, that was great. That was especially good because you covered all the biology part that I'm not gonna have to go into. I'm really gonna focus a little bit more on sort of the activities going on right now at ASU in terms of sort of how we've been thinking about responding to the issue. I think one thing that Mara covered a little bit, and I'm just going to remind everybody, is that, you know, the way viruses spread is person A, the blue person spreads it to a first level of green people. The green people then start spreading it to other people, and so on and so forth. And I think the thing to remember from all of this is that transmission is not simultaneously; it occurs over time. And the idea for testing, in terms of preventing the spread and flattening the curve, is that we want to catch it early so that these subsequent events don't keep happening. I think the other thing that has been emerging a lot in recent publications, this is a paper from Science at the end of March, where they looked at 40 documented cases where they could clearly source the source individual and then the person to whom that spread, is that a large fraction of the spread of this particular virus appears to occur either asymptomatically or especially pre-symptomatically. And so let me see if I can get my mouse up here to, yeah. So if you look at what's in this color blue right here, this is transmission occurring pre-symptomatically based on the models that they developed, looking at these documented cases of transmission. And tau is the time from the time that the person presumably got the infection, based on sort of back calculating when the exposures occurred. And so their estimation is somewhere around up to 50% of transmissions are occurring pre-symptomatically. And then this paper just came out in Nature Medicine. And again, they're estimating that around 40% or so of secondary cases were infected during the index cases pre-symptomatic stage. So people are spreading this virus before they know it, and that more closely models after what sometimes occurs in influenza.
I might put, I'm on.
Mara, you may need to mute yourself there. And then, but not so much SARS. The SARS virus that we talk about tended to have its peak infectivity after symptoms, whereas here, people can be spreading the virus before they know they've got it, okay? And that's, I think, emphasizes why it's gonna be so critical to do testing. So, you know, we've been thinking here about, you know, how do we go offensive against this virus? Social distancing is great, but probably not sufficient, and certainly gonna be problematic if we ever wanna get, you know, society back in action again. One of the focuses that our group has been doing is thinking about testing all cases and thinking about essential infrastructure personnel, particularly people like first responders, people who cannot maintain social distancing as part of their job. Key to this is identifying positive cases, getting them under quarantine, and then doing thorough contact tracing of all the people they've come in contact with and getting them tested so that they can be also quarantined if they're positive. Because it's the contacts of the positives who may be shedding virus but don't know it, and that's our sort of best window. Ideally, we would test everybody. That would be the perfect world. That may not be feasible initially, although I would agree with Mara, we need to be doing a lot more testing than we're doing right now. And so, but at the very minimum, let's be extremely thorough in testing everybody that's positive. So almost exactly 4 weeks ago, we started getting serious about what we could do at ASU. With the notion that probably the most important thing to get moving was testing. And so we set up the following teams that I have listed here. We set up a team on sample procurement. At that time, in the state of Arizona, from talking to a number of hospitals, there were probably only a couple thousand sample collection kits. That is to say, the swabs that Mara was talking about, along with the media, the transfer media that comes in the tube. There, you know, the hospitals, some hospitals we talked to had only 200 kits in their entire hospital. And they went online and couldn't even get them. So we set up a team specifically focused on getting swabs available, and then how do we actually collect samples in the most efficient manner. And so Joe Maselli leads the team on collecting the equipment, and Dave Thomas set up teams for actually collecting samples. And we set up teams to do viral testing, and we have been focusing especially on testing for the virus. And while I do appreciate the value of the serology, my own view on this is that in the state of Arizona, probably 1% of the population has been exposed to the virus. I think the vast majority of people in the state have not yet been exposed to virus. And so the serology is not going to be as informative as telling us who is actually shedding virus right now. We had to set up database tracking and a participant portal. This is to track the barcodes on all the samples and link them back to the participants so we could know who was positive and also manage the data. We started thinking about a contact tracing team. How do we actually track people who have been in contact with a documented case? Keep in mind that right now in Maricopa County, there is no active contact tracing going on. So people who test positive are given a piece of paper that says, please contact all the people you've been in touch with and encourage them to get tested. That's as much as going on right now. And we think a more active program is probably needed for the moment. We need to think about regulatory clearance for all of this. We had to be able to get communications out the door. And then Tamara Doozer has been leading the effort on building partnerships with groups that we can help get tested. Heidi's been leading the effort on the communications. Mitch McGee has been tireless in getting things going on the regulatory clearance side. And Scott Jacobson is leading the team, and Tim Lant is an epidemiologist extraordinaire who's been really doing a lot of the modeling for this. And he sits on committees related to the state and how they're doing the modeling. Okay, so here's what we came up with. Here's our workflow. As I mentioned, we have a participant portal where people can get online and actually register to get tested. When they fill out the various forms online, and this is all cell phone enabled, as you can see, it generates a VR code that we can then scan at the site so that we can know who's coming. And then the site also links that to a barcode here on the actual sample when we collect the sample. Samples are collected, they're brought into the lab. We actually heat and activate the samples so that they're not infectious. And then they go through an automated assay in our lab. I'll come back to what assay we're using for that. We then analyze the data from that sample and then provide that back to whatever entity we're working with that, where the sample gets collected. And then to them, we actually deliver the results and they let people know kind of what the outcome was. All this is being collected into a database, which is managed under HIPAA. It's a HIPAA compliant database. I'm not going to go through the details on this slide, but just to kind of show you, this is kind of the participant portal sign-up instructions. Here's the actual testing service and kind of a description of what people can expect. You'll hear a lot about this in the news and elsewhere. It turns out that probably one of the most efficient ways to collect samples, particularly if you're collecting the nasopharyngeal sample, which Mara talked about earlier, is in a car, because the car acts as sort of a barrier to prevent an individual who may be infectious from infecting everybody else. So if everybody went to a waiting room at a clinic, then one person in the room could infect everybody else in the room. Plus they're touching doorknobs and they're touching surfaces and all that other stuff. Whereas if they're in their car, they're only affecting their car. The healthcare personnel can just reach through the window of the car, collect the sample, and our team has got this down really efficiently. So this is some of the stuff that's been going on in terms of logistical support to get samples and collection kits available. We realized that we're a university, so even though we couldn't easily buy the viral transfer media and the tubes, we could make them. So we just made our own buffer, got our own tubes, and just essentially assembled all that. And in the meantime, Joe has been incredibly active online finding sources of nasopharyngeal swabs. To date, we now have 78,000 nasopharyngeal swabs here. So we are doing well on that. So we've dramatically improved what's available in the state. And we are partnering with our clinical partners around the Valley and the state. If they need them, we share them. So we've been handing them out to others who can't get hold of them. Meanwhile, there are 3D printer teams at ASU that are actually manufacturing some of these swabs. And we are talking to other groups that are talking about making even more of them. We've made up to 30,000 tubes. Then we've purchased 30,000 commercial tubes for people who prefer to use those. And we've made about 15,000 tubes ourselves. We can produce collection tubes at the rate of about 2,000 a day here at the Biodesign Institute. We are also in Arizona, ASU, making face shields. At Biodesign, we've made about 2,000 of them downstairs in the basement here. And now I think Luminosity Lab has sort of taken that over, and they're producing around 300 a day. These are disposable face shields. And now we're also, the 3D printing group is actually managing some reusable face shields, along with some methods for cleaning the face shields. And then this is what our collection sites look like, so you can get a sense of what that looks like. Here you see, and I got a shout out here to the Edson College of Nursing and Health Innovation. They have been fantastic partners. Nurses from all over our schools have stepped up to help us collect the specimens. It's important to know that when cars come, they don't just drive in off the street like you would at an In-N-Out Burger. They have signed up online in advance, so everybody knows their time slot. Everything is very orderly, so everybody knows when they're supposed to be here. Typically have 2 different sampling stations running simultaneously, and they can collect at a station 45 samples in a 4-hour shift. That's about 3 minutes a car. That's how fast. Show me any clinic around that can collect samples from people in 3 minutes. I don't think they exist. So this is really an efficient way to get samples collected. I will say, it is one of the limiting things is having to have nurses or people who can do nasopharyngeal swabbing. There are some, I know Mara's slide suggested that oral sampling is not as good, but there are data now to challenge that. You know, typically when people are viral positive, they are very viral positive. And if we could switch to an oral sampling, we could collect way more samples. And I think if we want to get to the sort of 10-fold number that we're all talking about getting to, we may need to switch to oral sampling instead of nasopharyngeal sampling. Sputum are going to be hard to get for people who are asymptomatic. And I think we need to move into the asymptomatic population because, as I pointed out earlier, people are probably most dripping with virus around a day before they become symptomatic. So we have to think about that. So in terms of actually getting the testing, our lab was helped by the fact that we had just recently completed a project for BARDA that was basically a qPCR assay that involved automation. We had to demonstrate for them that we could do 2,400 samples in a 24-hour window. So we had already automated qPCR testing. The assay that we had was more complex. It involved 13 genes. This one only involves 3 genes along with a positive control. So, and we already had GLP practices in place along with a very detailed quality management system. So we had a lot of the elements in place for becoming a CLIA lab. And so that's what we did. We became a CLIA lab. This is the kind of outline of the equipment that we use to do the sampling. First, we have to get the samples that come to us in tubes with nasopharyngeal swabs transferred into blocks. Initially, we were doing this manually in a biosafety cabinet. Now we've trained a robot to do this, and it's actually more efficient. So we still need people to look at the tubes and confirm the barcodes and the date of birth. Always 2 forms of ID on every tube. And after they do that, they align them in racks, and then a robot then collects the sample out of the racks. The samples get moved to this Kingfisher right here, where we extract the RNA from the virus. And then that sample then gets put over to this robot here, where it's transferred to blocks and the reagents are added to run the samples on these qPCR instruments here. Each of these instruments can do 384 wells at a time. So our testing capacity with all this automation is, I'll just say, high. We're nowhere near touching what we could do, particularly if we added multiple shifts. Easily, I think we could hit over 1,000 sample testing a day, but I suspect we could probably double that. So we just need to get the samples in. This is the bird's eye view of the test. I'm not going to go through this in detail. The main thing to remember is that we actually test for 3 of the genes that Mara showed in her slide of the overall genome of the virus. We test for 3 genes, and we also add a virus to every sample and we test for that virus. It's not related to the SARS-CoV-2 at all. It's just to show that the extraction worked and that the PCR worked. So there's a positive control in every sample. And because of that, this is what the data look like when you actually read them on the instrument. I'll start on the right-hand side. This is a negative sample. You see in yellow here, that is the curve for the positive control, and we should see that for every single sample. Over here is a positive result, and what you see is the positive control in yellow, and then a blue, a green, and a red. These are the 3 genes from the virus that are also positive. And the official FDA authorization for this says that you should have at least 2 of these 3 being positive. In every sample that we've tested that's been positive, all 3 have been positive. And our limit of detection is around 0.5 virus particles in a 1 microliter sample. So it's quite a sensitive test. In terms of regulatory, we have obviously our safety approvals in place, as well as an IRB approval that was fast-tracked for just collecting results. Since then, we've submitted a full IRB to do research as well, and that is nearly complete. We are CLIA certified now. Carolyn Compton is the lab medical director, and we now have also received FDA emergency use authorization, and that's in place. We're maintaining our quality systems documents, and of course, we also have a CDC import license so that we can bring in samples from outside sources so that we can start developing our own serology assay. I will mention, I don't have a slide for it, that we are developing serology assay. Our assay will test for, in addition to the specific proteins for this virus, it will also test for all of the proteins from all of the previously known coronaviruses. And we're particularly interested to know if exposure to a previous coronavirus has any impact on the clinical outcome of someone who gets exposed to this virus. Is there partial immunity there? Does it lead to a milder outcome or a lesser intense activity? We don't know yet, but our test would be able to look at that. And so we're hoping to get that up and running. We're actually developing the proteins for that right now. Lastly, I think what's really needed here is contact tracing. We're gonna get some positives. The most important thing then is to immediately find all the people that those positives have been in touch with in the last several days and get those people tested. That's the way we catch this virus before it spreads, and that's the key here. The R naught for this virus is around 2. That means, as you all have seen, exponential growth. And if we want to stop that exponential growth, we need to catch people before they're spreading it, and the way to do that is to do thorough contact tracing. In the perfect world, we would have a little lapel pin that we would wear, and it would turn red when we're infectious. And we would immediately know to send those people into quarantine until the light went off. But we don't have that, and what we need instead of that, or the closest we can get to that, is testing for people who are shedding virus by sampling their throats, perhaps even on a regular basis for people who are frequently exposed, and then looking for the presence of virus. I will stop there, and I think it's time for doing questions.
All right, thank you very much, Josh, for your great talk here. So we have a number of questions on the board here, and I'll start asking them. Well, I'll actually start with one that I have here, and that probably more towards Mara at this time. And you know, there's a number of reports about various types of tests that have been purchased by various health care centers as well as countries, including, like, for instance, the one in the UK where they purchased like $20 million worth of antibody tests, which ended up not working. So, with the US and the rapid sort of CE markings that are being given out, how do you think ASU can impact the quality and standardization of diagnostic testing, especially in times of crisis, such as what we're experiencing with the COVID-19 right now?
Well, I'll give a quick answer to this, if you can hear me, but I actually think that Josh's presentation really underscored the core to it. ASU is unique in having a program focused on biomedical diagnostics and biodesign to really understand the science behind it. While I appreciate that many entities, countries, Telluride in Colorado was another example of a city that jumped on it, bought a whole lot of tests and found out they're not effective. So I think that they need Josh and his team right next to them to ensure that the test is indeed as sensitive and specific as necessary at the right time.
I don't know if Josh, if you had anything.
Yeah. I mean, I think, yeah, the serology thing is right now it's a bandwagon that everybody seems to be jumping on. And there is no doubt in my mind that serology is important. In fact, Lord knows, far be it from me to diss serology. My whole career has been based on serology, right? But I think we have to keep in mind what we're trying to accomplish with serology. Serology will be extraordinarily important when we start getting vaccines, because it'll be the way we know who is resistant and who is not resistant to the virus. But my current belief is that the vast majority of our population has not yet been exposed to the virus yet. And I think that's especially true in the state of Arizona, where I won't say we were the earliest to do social distancing, but even before the governor asked for lockdown, people were already socially distancing in our state. ASU had already gone to an online teaching at that point. And you can actually look at the statistics of the growth rate of the virus in the state and see that by mid-March already, there was a change in the inflection of how the spread of the virus here. So I think what that tells me is that most people haven't seen the virus. Most people are still susceptible to the virus. And so I think what serology is going to largely show is that you're going to see most people are going to be negative. That said, we need a good test, and we need to know what needs to be in that test. And that's why I think before we start selling kits, we should be doing testing on those kits and verify that the kit is really useful in terms of what we're going to use it for.
Great. So I have I have one of the audience asking a question in terms of are viral copies a copy of the same strain? Do we know if COVID-19 is mutating to the point that the antibodies may develop, one may develop, won't help if they get sick again? So I guess what impact is the mutation rate of COVID-19 having in terms of the efficacy of these tests?
Josh, you want to start with that one?
Yeah, that's a great question. So first of all, we definitely do know that the virus is mutating at some level. For example, we know that most of the cases in New York State came from Europe, not directly from China. So that was probably how most of the cases got to New York. You can also identify, so you can see subtle differences from virus to virus. What we don't know, which is the important question that was asked here, is whether or not those mutations are going to affect the spike protein, which is probably the protein that most people are using to develop the antibody assay. And then what that could mean is, for example, you would get a false negative result there. In other words, you would say the person is not responsive. Well, that people would be immune to one virus, but not another. We just don't know that yet. And that's, again, why it's so important to actually do studies on these serologies to see how much do they confirm that the person is resistant. More likely than not, if you have antibodies to the virus, you'll probably at least be resistant to what's going around in your area at that time. And so I think it'd be probably fair to say that for a year at least, you'll be good. Whether or not this is going to change as frequently as the flu virus does, which is kind of a year-to-year thing, we don't know yet. We need to get more data on that.
Okay.
And I would just add two quick things to Josh's answer. One is we do, as Josh mentioned, look at other diseases like the annual flu and AIDS and how the HIV virus changed a lot over time and then stabilized. But that in addition, I appreciate the FDA opening up and relaxing constraints. But as I talk about phase 4 data, I think it needs to be out there for these serology tests. So while ASU is doing a great job under Josh's leadership, we need to get the epitope data by manufacturer to understand, is it different in Arizona than it might be in New York or California or Italy? And that these need to be put into a national or international database to get a larger sampling and to better answer those questions quickly.
Great. This is one that's a question directed to Josh. Can and should we implement this testing and retesting process for students, faculty, and staff as part of our strategy to get back to in-person classes? What structures and functions would be needed?
Good question. So the question is, who do we test and how much testing do we do? I think we all agree we need to do much more than we're currently doing. On the other hand, it is not an insignificant cost to do these tests. So the question is, what is the kind of best epidemiological model for this? And that's the question that I've actually put to our epidemiological team. They're actually sort of thinking that model through right now. Here is sort of on a tier level how I'm thinking about it. Top tier, of course, is anybody who's symptomatic should be tested, and there should be a low threshold to get a test for anybody who's got a cough or a fever. You should just get it for everybody who has those symptoms. Anyone obviously who's positive at that point immediately needs to have contact tracing done. So everyone that person's been in touch with needs to be tested, immediately. The next tier down would be people who come in contact with a lot of patients. So healthcare workers, first responders, anybody who, meets a lot of people and comes in close contact with them should be tested on a pretty regular basis. Probably the next level priority would be people who in the course of their work cannot maintain social distancing. Particularly folks who are playing key roles in infrastructure jobs. You can imagine there's a lot of things that run in our society that need to keep running, and we need to have a lot of people who run those things. They work in control rooms where they have to be close to each other. There's no way around it. So we probably ought to be testing those folks. And then we get to sort of the broader community as a whole. And then, in the state of Arizona, we're talking about 7.2 million people roughly, right? So it's going to be hard to test all those people for virus. So then the question is, then we come back to kind of the beginning again, which is certainly folks who are symptomatic. I would say for your average student, your average faculty member who has no reason to believe that he or she has been exposed to virus, probably doesn't need to be tested right away, but I would have a very low threshold to get them tested if they start to feel ill in any way.
Okay.
So, and Carl, let me just add to that, because I agree with Josh's prioritization. I will say it's been public that U of A has said, and they're focused on serology testing, that they will move forward to test everyone associated with the university. So it'd be interesting to see how that plays out, and that has not been made public yet. But I think as Josh talks about those who are no reason to believe they had exposure, I think we have an interesting issue as shown in China as to the role that children have in this virus. There's reason to believe that children may be harboring the virus, and it's clever enough to have no symptoms in them. So in hotspots like New York and some other key cities, we may be testing more broadly and testing every member of a family. Serology testing, that is.
Great. All right, thank you. Next question is, with the goal of expanding testing capacity and potentially moving those tests into the home, finger sticks seem like an optimal collection method. How sensitive and specific are finger stick blood tests so far compared with MPS, et cetera?
I'll start there, and Josh, curious at what you think. I mean, there are too many of them to give a broad answer. It's not the finger stick in and of itself, as long as it avoids interstitial fluid and gets blood, that should be fine. It's the design of the actual assay and which parts of the genome they're analyzing. So it has to be looked at one by one.
Yeah, so I'm a little confused here because a finger stick gets more at the serology assay, right? That's typically what we do.
Yes,
I don't know that there's that much, there's not a lot of good evidence for a lot of virus in the blood. I think some people have found it there and certainly other coronaviruses, but to me, the most useful test is to determine whether in the nasopharynx someone has virus, because those people are infectious and those are the ones we want to get quarantined. The thing about a finger stick assay for serology is the upside is it's easy to get a finger stick in terms of the access to the blood. If the goal is to get people back to work and to figure out who is resistant and who isn't, ideally you want to be collecting that information somewhere to be able to make this person is safe to come back to work judgment, right? And so then the question is, in terms of how do you enforce it? Do you just let people take their blood tests at home and expect them to give you accurate answers, or do you want someone to witness it, or should they be doing it at the health clinic? So, probably finger stick is the best way to get the blood, but the question is how we administer these things, and how, from a safe to work kind of perspective, I think there are still questions about how to do that in the best possible way.
Next question is, where do you think the antigen tests fit in to this picture, or does it fit in?
What do you mean by the antigen test?
The viral
antigen. Viral antigen, yeah, sorry.
I'll let Mara do that one.
I think that if we could get one that is accurate, and there are a number of companies looking at this, I think it has tremendous power to be able to be useful and to be able to do it either the sampling or the test at home. So I think the viral antigens is the next group of tests that will happen. The problem is, and this is another example that you had mentioned, Carl, of countries with challenging. Spain had looked at this, and they found that 40% of their initial batch of testing was indeed incorrect. So I believe there will be viral antigens in the next wave of testing, but we're not there now with ones that are sensitive and specific enough.
Okay, thank you. All right, next is, as we look at states such as California and New York, do you feel that California has experienced some sort of herd immunity months prior before we knew? Do you feel the disparity in number of cases in each state suggests this?
I guess, Joshua, I'll start briefly to say it's hard to believe that there is a herd immunity. California was one of the very earliest ones to do social distancing and sheltering in place, and their density, even in their cities, is far lower than New York.
Right, I'd agree 100%. I don't think we're anywhere near close to herd immunity. In fact, I would go the other direction and say that, in fact, I think the vast majority of folks in the country, certainly on the western side of the country, where things are more spread out, is the vast majority of folks have never even seen the virus yet. They've never come in contact with it. And so I think it's going to be a while, and probably not until we have a good vaccine, that we get to actual herd immunity. That one thing that I haven't heard yet from any of the questions, and I'm surprised by that, is the use of digital tracing. Because one of the things that's been most successful, particularly in Asian countries, probably the shining example of this would be South Korea, which South Korea has the entire number of deaths. So keep in mind, first of all, that South Korea has 50 million people, so it's a sizable population. But the total number of deaths in South Korea has been less than New York on a good day. In total over the entire virus. And they are not locked down. They are still functioning as a society. And one of the keys to that approach is that everyone who gets tested agrees to have the information about their test added to digital tracing. And everybody has an app on their phone, and their phone will alert them if they are near someone who has tested positive, because the system knows this. And so they are instantly alerted about when they're near someone, and they know to go get tested or they know to get away. And the question is whether or not the United States would be prepared to start thinking about that sort of thing.
Okay, great. This may actually be the last question. Unfortunately, we can't do all of them. There's a bunch of the others, but this next question is, the sailors on the aircraft carrier Theodore Roosevelt had been tested, and about 60% of them that tested positive were asymptomatic. What are your theories about what impacts symptoms and whether none mild or severe for that?
Mary, you want to go first, or?
Yeah, well, I'm not surprised by that. It's a typically young population. And as we have seen, and I went through my model, that as many as 50% of people will indeed be not asymptomatic for the course of their entire disease. There was another study done in the US with pregnant women, and 82% of them that were positive were completely asymptomatic. So I think that we find that the variety of this, going back to the virus itself, the amount of viral load may be the issue here, or as Josh mentioned on the serology test, to find out that if people have been exposed to other coronaviruses, bring on fewer symptoms. But this is not atypical of the seasonal flu, where some have it much more aggressively than others. So I'm not surprised by the data that just came out today about the Navy ship.
Yeah, I agree with all of that. I think, the suggestion, even from, the experience in China, was that, I think it's been found elsewhere, that around 80% of people who get this virus either have mild symptoms or no symptoms. And then, but the tricky piece is that many of them may still be infectious and contagious. And a lot of the more recent evidence is suggesting that people, can transmit the virus even before they're symptomatic or asymptomatically.
All right. Well, thank you very much, Mara and Josh, for a wonderful talk and your thoughtful answers to the number of questions that are out there. I'm sorry we didn't have time to address all the other questions, and we have a number of them. Maybe we'll find some way to address them, maybe online in some manner. But I also want to thank everyone that attended to spend the hour with us talking about COVID-19. And I hope that you will join us for future editions of the health talks that we'll have through the College of Health Solutions. So with that, thank you. Have a good day and stay safe.